Welcome back to my channel, Pattern of Good Works. My name is Donna, and today we will be in the book, which is titled The Specialty Practice of Rehabilitation Nursing, a Core Curriculum, the 8th edition. In chapter 11, where we are starting on page 196, and this is part 2 of bowel and bladder care. So at the top of page 196, the header says, Nursing Assessment for Fecal Continence. Last week we talked about continence, so you should remember what that means. The rehab nurse completes a thorough bowel assessment that accounts for risk factors for bowel dysfunction. It goes on to say that neurological injury or disease is the greatest risk factor for constipation or fecal incontinence. So let's look at what constipation is. So Merriam-Webster says that constipation is abnormally or delayed or infrequent passage of usually dry, hardened feces. The book says that constipation is the most common digestive problem reported among adults. It is a subjective complaint, which is why it is important to distinguish between client perceptions of problematic bowel habits and true constipation. Constipation is generally a reduction in the frequency of bowel habits, and they put it as fewer than 3 stools per week. And it is often accompanied by prolonged straining with compacted, hard, or dry stool. Management begins with conservative approaches such as optimizing dietary and fluid intake and routinized and unpressured toileting. The duration of constipation is less or more than 12 weeks, defines constipation as whether it'll be acute or chronic. So the book gives a description of acute constipation, and it says that it's generally a hospitalized client who's under emotional stress and is experiencing a disruption in the normal patterns of living. And this client typically has acute constipation related to new medications such as an analgesic or an opioid, which will slow the gut motility. Clients who have undergone surgery or are suffering from a traumatic injury will be less attentive to the body signals to pass stool. They may have the urge to go and maybe just, put it off and ignore it. So this is largely caused by the sympathetic nervous system's inhibition of digestion when the body is stressed or in pain. So in acute care settings, let's say the intensive care or medical surgical nursing units, the focus on the client's medical stability and less on the regular patterns of elimination of the patient. And this typically carries over into the acute rehab stay, and clients may report that they have not moved their bowels since before they initially arrived at the hospital. And this can be as many as 10 days, which they haven't had any passage or any bowel movement in a lot of cases. So the management of acute constipation begins with the evaluation of the anus for rectal obstruction or impaction. So the rehab nurse is going to evaluate the perineum for signs of obstructive feces, according to the book, and provides disimpaction care if needed. Anal skin is assessed, so that's visualization, for hemorrhoids. Hyperosmotic laxatives that draw fluid back into the colon are very helpful in promoting stool evacuation because the goal is to get the stool out. More aggressive stimulant laxatives should be administered with caution because they can increase GI distress, gas, bloating, and cramping. Now let's compare and contrast the difference between acute and chronic. So chronic constipation, it says that a client's symptoms must last for at least 3 months with 2 or more of the following. So they initially say straining during more than 25% of defecation, lumpy or hard stools in more than 25% of defecations. There's a sensation of incomplete evacuation for more than 25% of the defecations. There's a sensation of anorectal obstruction / blockage for more than 25% of defecations. manual maneuvers to facilitate more than 25% of defecations, and that's really digital evacuation. And then fewer than 3 spontaneous bowel movements per week. Chronic constipation is considered a functional bowel disorder and can be classified as either normal transit constipation or slow transit constipation. Treatment is intended to optimize the quantity of fiber in the diet with proper fluid support. It goes on to talk about all the types of foods that really lend themselves to worsening the condition. So here we go. Dairy, which is cheese, ice cream, whole milk, yogurt, red meats, or tough meats, processed foods, snack foods, cookies, meals from fast food restaurants. And it really highlights also a high fat diet with inadequate consumption of starchy vegetables or whole grains. And this is felt to worsen chronic constipation. So as we reviewed constipation, we see the need for cognitive awareness and for someone to be attentive. So let's kind of explore that now. So functional deficits combined with cognitive impairment will reduce self-care capabilities. If someone is cognitively impaired, it's going to be hard for them to remember whether they were straining. It's going to be hard for them to remember, how many times did I go to the bathroom this day or this week. It's imperative for the rehab nurse to be mindful, to see and assess whether or not this patient has reduced insight, awareness, and understanding about those body signals to defecate. It also goes on to say that specific neurological injuries will cause neurogenic bowel dysfunction, which is also complicating functional and cognitive abilities. Additionally, narcotic-induced constipation increases the incidence of chronic constipation and other functional bowel disorders. It says that medications such as opioids, psychotropics, antidepressants, NSAIDs, beta blockers, clonidine, diuretics, and anticholinergics, that's a lot of medication, can cause constipation. Medications associated with loose stool include antibiotics, antidepressants, and acids, proton pump inhibitors, and chemo agents. Clients with premorbid bowel disorders are at increased risk of experiencing a repeat incident while in an acute rehab program. So, what disorder could they possibly be talking about? So the Mayo Clinic says that irritable bowel syndrome, IBS, is a common condition that affects the stomach and intestines, also called the gastrointestinal tract. Symptoms include cramping, belly pain, bloating, gas, and diarrhea, or constipation, or both. IBS is an ongoing condition that needs long-term management. The book says that IBS often coexists with other chronic syndromes. It says that fibromyalgia, chronic regional pain syndrome, gastroesophageal reflux disease, and psychiatric disorders. So we know the nurse is going to be completing a physical assessment. This physical assessment, which we know should be head to toe, is going to allow the nurse to interview the client, assessing them for flags and different symptoms like blood in the stool, narrowing of stool, any unintentional weight loss. They also will, of course, like we talked about earlier, assess their neurological status by asking questions related to orientation. Are they able to follow commands? Are they able to recall information? But one thing we want to ask or assess is, are clients with steatorrhea? And steatorrhea is a malabsorption disorder. And clients with steatorrhea, which is fatty, malodorous, or greasy diarrhea, may be unable to properly absorb fat. And this is common in clients with chronic pancreatitis, clients with immune mediated allergies, such as celiac disease or lactose intolerance, experiencing painful indigestion. They also may have bloating, cramping, and urgent diarrhea after ingesting gluten or lactose. And the gluten would be celiac disease, or lactose, which would be lactose intolerance. The priority in managing celiac disease is simply to avoid foods containing gluten, such as wheat. Likewise, avoiding all lactose containing foods, such as dairy, is the best management plan for lactose intolerant clients. Today, we were grateful that we had the opportunity to explore various types of bowel dysfunction. We talked about constipation, IBS, steatorrhea. We also looked at the importance of cognitive status, or the role that cognitive status plays in bowel management. I want to thank you for coming along on this journey. I would ask that you like, comment, and subscribe, share with a friend, and be sure to get ready for the upcoming window for the CRRN examination. I know you can do it, and I'm praying that you will continue to look to the hills from whence cometh your help. I know your help coming from the Lord. Take care. Bye bye.